get this topic front of mind, write them down, and as we go on, there'll be lots of chance to, I think, spark more questions and discussion. My little job here today, can everybody hear me? Yeah. My little job was to give you kind of a science class before we got started in talking about the medications, because I think it's really nice before you talk about treating something to try and talk about sort of what is it, and what are we really talking about, what's going wrong in the brain when we start to talk about dementia. So that's my job. And I thought I would start by just giving you a little bit of history. Now this is Dr. Alzheimer on the right-hand side, and we're talking tonight about dementia. Not all dementia is Alzheimer's per se, but it's a pretty significant portion, and it's one of the kinds that we talk a lot about in society and in the media. So I think it's a good place to start. Dr. Alzheimer is on the right, and the patient that he really started puzzling about is on the left. This is Augusta Dater. And he had this patient he couldn't figure out. It was unlike anything they really understood, because she had really significant short-term memory problems, as well as a lot of behaviors that didn't seem to make sense. And she was only 51. He really didn't figure this out, and he really puzzled about this patient for a lot of his career. So when the patient died, and it was back in 1906, it was quite a privilege to be able to look at what was happening in her brain. Really fortunate that could happen. And what he found when he actually looked at the brain, and this is really microscopic, is that this doesn't look like normal brain tissue. There were two things that were kind of extra. There were little globby clumps of things, and we call those plaques, or amyloid plaques, because we've figured out since that it's made up of amyloid. And there are also these sort of bushy little things that they call tangles. So there's these globby clumps, and then there's the bushy little tangles. And it was interesting that it was so very striking that this brain tissue looked different, and yet what is really going on and why all of those things have happened and what really gets it started, kind of still a mystery. We're closing in, but really we haven't gotten so much further than Dr. Alzheimer did. And it took him quite a few years to even get the disease named after him, but it was a pretty important discovery. So this is taking a look at a slightly different level. These are brain cells, or sometimes we call them neurons or nerve cells. This is what makes your brain is all made up of a whole bunch of these cells. This guy looks really good. That's what he's supposed to look like. You can see he kind of looks fit for his job, which is communication. The brain is a whole network of these cells, all trying to communicate every which way, talking to one another, all sorts of different routes of communication. He's up to the job. That guy on the bottom, he does not look like he would be as efficient a communicator. He's got a lot of green blobs around him, which are those plaques, and he's got a lot of those red tangly things inside his body that are not, it just doesn't look like he's up to the job. So this is giving you a bit of a picture of what that communication looks like. So these nerve cells are in charge of passing messages from one cell to the next. And it's a lot like Grand Central Station in Boston and Grand Central Station in New York. These two massive hubs of communication, and somehow the messages have to get from one to the next. So they have to originate here, get all packaged up and be prepared. Then they have to head down this transit way, which might be a railway, or it might be a street or a highway, and then somehow they have to get to the right place in New York. They have to, the packages have to be offloaded, and they have to get all distributed to the right places. So this is the perfect situation. The brain does this with chemicals. So the messages are formed in here are certain chemical signals, and the chemicals get sent along that long pathway, and then they get dropped off down at the far end, those little tiny blue dots, and hopefully New York receives the signal. So this is the perfect scenario when it's all working well. We'll zero in. So now it's going a little bit backwards, but so the messages are coming in, down over on that side. They're coming down this pathway. Here are all the little messages. And this part's the kind of nitty-gritty where the rubber hits the road, where these are all the little chemical signals, and they're getting all packaged up. They're getting dropped off here. But this is kind of like dropping them off on the sidewalk. They've made it to New York, which is over here, but they're not quite at their destination. So the little chemicals have to be received. These are little receptors that are in New York. They're kind of like mailboxes or maybe loading docks where the packages all get dropped off, and they have to get to the right destination. So this is important because a lot of the medications that we have to try and look at trying to make things better, trying to treat the symptoms of dementia, really focus on what's happening in the signaling at this level, at how the packages are getting packaged up and how they're getting dropped off, and whether they're getting to the right loading dock in the end. And we can modify that a little bit with some success to try and make sure that the message gets through as efficiently as possible. We really have to be efficient with the message because, if you remember, the stations are really, they're not fully operational. If you think of these big nerve cells as the stations in Boston and New York, they've got all those plaques around them, all those clumps of things, so they're kind of constantly under construction. Right? There's doors and entrances that are blocked. There's whole sections that they're not able to use. You can't go the normal routes you want. So the stations are under construction and globbed up with all those plaques. And all these fibrils that are supposed to look like nice little message pathways are kind of tangled and messed up. So the tracks for the train or the highways are all a bit under construction too. So the signaling needs a lot of help. So what ends up happening is it's a lot like the summer season in Kingston, where it's 2 seasons construction and the rest of the seasons. And so what happens is sometimes every road seems to be under construction. It's not just one road. If Princess Street is under construction, you might be able to take Bath Road. And so if this is Princess Street, you might be able to reroute on Bath Road that's clear. But if Princess Street and Bath Road and maybe Front Road and some lane widening on the 401 is happening, all of a sudden the routes are you don't have as many choices, and you're having to take a long way around if you're going, kind of like going from downtown Kingston to Minos via Sydenham or something like that. So that's a lot of what's happening in the brain when the pathways get messed up. It's kind of like sending these little chemical signals is like exercise for the brain. The brain is quite happy when it's sending signals. That's like good exercise, it's doing its thing. If you don't exercise, what happens? You kind of start to get a little out of condition. In the brain, that looks like shrinking. So this is a brain that's kind of it's a little piece of a brain. And this is what it's supposed to look like. It's all plump and fit, and it's really able to work. On that side is a shrunk brain of somebody who's had a pretty severe dementia. So that's a pretty advanced picture, but it gives you an idea of how if the brain isn't working in all of those places, it's going to shrink down and you're not going to, it just doesn't look like it's going to be up to the communicating like this guy would. You can sort of see that it's not working as well. You can imagine that anyway. Now that process where the plaques and tangles all start to form and then those little pieces of the brain don't work, it doesn't happen over the whole brain all at once. It usually starts in certain areas, so you get some symptoms that happen first when those areas are affected, and then as time goes on, maybe it spreads out more and more to the point where you see a lot more changes that add up together. So what we often see in a kind of regular scenario is maybe the area for language, the little part of the brain that's responsible for language. If it gets a lot of plaques and tangles, you're going to start to see a lot of those messages not getting through efficiently and a lot of rerouting, and maybe some of the words don't come as quickly as you'd like. Or maybe understanding complex conversations is difficult in real life because the signaling pathways in the brain are not being very efficient. Or maybe it affects the memory area, and you see that the memories aren't being laid down as well, especially those short-term memories. So it's harder to make the new memories and to get them back, and that's because the pathways are all disrupted and the signaling isn't very efficient. So you see all the different areas of the brain, depending on which area has a lot of plaques and tangles, are going to be more or less affected. So that's really my little science talk about the brain. You see there's lots of different areas all responsible for kind of different things, and it's a very complex system. I didn't have to tell you that, right? So it really depends on a lot of those interconnections. It's not just Boston to New York, it's Boston to Philadelphia, and Philadelphia to New York, and New York to Toronto, but also Boston to Toronto, and Philadelphia to Toronto, and a whole network of roads. So we really, it's really important when you talk about connections and signaling to think that it's quite a delicate system, and you can do a lot to upset the balance either with medications or with changes in the brain.
I'd leave one slide up, we might come back to this. So Chris had asked me to try and build a little bit on what Melissa's already told you, and then maybe try and set up what Dallas is going to talk about. And I'll try not to step on their feet too much, but there may be some overlap as well. So again, now Melissa's talked and really nicely set up, I think, going from kind of the clinical picture to kind of under the microscope, and that I think really is useful. And just to reiterate a little bit about what she's talking about again, when I think about cognition, it's this umbrella term. We often think about memory, but as Melissa's nicely pointed out with some of the slides, memory, language, orientation, all of these things that make up thinking and make up largely who we are can be affected by cognitive disorders, and particularly the dementias, of which Alzheimer's is one that we kind of focus a lot of our discussion. There can also be more acute forms of cognitive disorder. We think acute confusion, which we see a lot in the hospital, what we call delirium. And often the pathways there that can be disrupted are similar, maybe not entirely the same, but similar to the ones that are affected in some of the dementias. And when we start thinking about causes of cognitive impairment, either acute or chronic, as a geriatrician, we often see older folks, and they're definitely more vulnerable to these cognitive disorders, both the acute and the chronic. And one place that we often focus our attention is on their medication list, because a lot of older folks are on a number of medications, and a lot of these medications, although they may have beneficial effects, can also have harmful effects, and often those effects can be cognitive. And so this circles back a little bit to what Melissa was talking about, because we start thinking about, how do drugs disrupt normal processes, like normal cognitive processes that allow us to remember things, both in the short term and long term, allow us to express ourselves appropriately, make sure that we are oriented in time and space. And if we think about this figure and the others that Melissa brought up, you think about disruption, you talk about, again, these backups on bathrobe, princess, and we think about maybe some of these mailboxes that she was talking about, and some of the packets that are supposed to get to the mailboxes. All of these processes seem to be affected. And the history goes back quite a ways. If we think back to actually some of the early neuroscientists, the first neurotransmitter that was identified was one called acetylcholine. And acetylcholine, that discovery of that neurotransmitter has a very interesting place in neuroscience. Before that, there was a big debate amongst the scientists as to whether the brain was predominantly just an electrical system, just a bunch of railway tracks and all electricity, or was there some soup component to it, the sparks versus the soup. And in fact, the answer is kind of a little bit in between the two. So electrical component is definitely very important and is part of the reason that the neurons work. But these chemicals, part of the soup, are also very important. And again, that discovery of acetylcholine by Dale and Lowy was kind of a really neat history, which I'll try not to get too involved in, otherwise Chris is going to get the king to pull me off.
We're equally talkative, so
So the recognition came sort of in the 70s, really, this idea from sort of multiple converging lines of evidence that the aging brain, even the normal aging brain, it seemed to be less acetylcholine, less acetylcholine action. So when we looked at, at these pathways, and if we imagine all these red dots, each of them was a little acetylcholine molecule. They seem to have trouble getting to where they needed to be. They seem to have trouble being released. And the mailboxes, the acetylcholine receptors, are called muscarinic receptors. There seem to be less of them expressed. And then there were also problems with the acetylcholine. Once it was in this space between the two neurons that needed to communicate, there were enzymes there that were trying to break down the chemical, and again, problems with kind of the balance of that breakdown and the new synthesis or new development of that chemical. So people started to say, well, loss of acetylcholine seems to be a problem. We have a number of drugs that are actually very potent blockers of acetylcholine. So they like to occupy these receptors, but rather than activating the receptors, they kind of shut them down and prevent the acetylcholine from doing its job, which is part and parcel of why these drugs, what we call anticholinergic drugs, seem to interfere with the development of what we would think normal cognition, so memory and language. And we know that people who take strongly anticholinergic drugs seem to have problems with their cognition. Could be either acute, meaning that they get acutely confused or delirious, or it could be more chronic. And that's a very important issue. The other recognition came that people with dementia, particularly Alzheimer's is kind of the prototype. With normal aging, we saw kind of a reduction in acetylcholine. With Alzheimer's disease superimposed on that kind of normal loss, there was an accelerated loss. And so this actually led to the development of something that Dr. Seitz will talk a little bit more about, which is a group of drugs that try to block the breakdown of what acetylcholine is left, and hopefully therefore will try and boost the levels of acetylcholine so that it can do its job properly. So there are these anticholinergic drugs, which I'll talk about more in just a moment, which we think can interfere with memory. And then there are these procholinergic drugs which block its breakdown, what are called cholinesterase inhibitors, and I'll leave that to Dallas to discuss more. Now, acetylcholine, I wish that was the whole story. So this story, again, from the 70s, people got very excited, tried to develop new drugs. That's not the whole story, and again, Melissa's talked about some of the other details. You have maybe a finer understanding from a basic science perspective in terms of what we call this amyloid cascade. We think probably the loss of acetylcholine is very much a last stage of the process. If we could try and find something maybe further upstream, we would have more effective drugs, hopefully, to combat the cognitive disorders, the dementias, and in particular Alzheimer's disease. There are other drugs that we think can also contribute to cognitive problems that may not directly affect this system, but may affect other neurotransmitters. And so we think, in particular, drugs such as the benzodiazepines. And in fact, many of you may have heard just in the last month, there was an important paper published from a group out of Quebec looking at benzodiazepine use and development of dementia. This was published in one of the big British medical journals. I think there's as there often is with a lot of these individual studies, some controversy still about what exactly the role is of exposure to benzodiazepines and development of dementia. But we do know that benzodiazepine use can contribute to both acute cognitive impairment and may also interfere with cognition more chronically. Opioid drugs, what are sometimes referred to as narcotics. So drugs like hydromorphone, morphine. These drugs can also sometimes interfere with cognition both acutely and chronically. If I stick with the anticholinergic drugs, there was a geriatrician back in the late 80s, early 90s named Mark Beers who had talked a little bit about when he went into nursing homes seeing older patients on often 10, 20 different prescription medications and realizing that a lot of those drugs either were directly anticholinergic and were actually being used because of their anticholinergic activity, often in other parts of the body, because aside from its role here, acetylcholine also has roles in many other organ systems. Sometimes, again, drugs have strongly anticholinergic properties, and we try and use them for those anticholinergic effects. Other drugs, although we don't recognize them as being predominantly anticholinergic in activity, when they're tested in test tubes, they actually do have moderate or potent anticholinergic effects. And so what he recognized was that a lot of older folks were on many potent anticholinergic medications, and many of these drugs had viable alternatives that were less anticholinergic, and so he came up with a list that has been updated periodically over the years, and it's now got his name attached to them, so that's the Beers criteria. And if you look through the criteria, these are drugs that are considered potentially inappropriate for use in frail older adults. A lot of the drugs on that list are in fact anticholinergic medications. Some of the benzodiazepines, particularly the very long-acting ones, are also highlighted as being potentially inappropriate in older adults, and a lot of this stems from concerns around their adverse cognitive effects. One of the big challenges, particularly with the anticholinergic drugs, is that there are so many different drugs that have anticholinergic effects. Some of them, again, we know about, and in fact, we use them because of their anticholinergic effect. Others, we use for completely different reasons. They have moderate or potent anticholinergic effects, but we don't think that's their kind of primary mechanism of action. And so when you actually try and sit down with an individual patient and go through a list of 15 or 20 medications, sometimes we'll recognize, oh yeah, this is a anticholinergic we're using to kind of calm the bladder down. But there might be other drugs that you say, oh yeah, this is a heart medication, or this is an antipsychotic, or some other drug, and you say, well, that's actually not, the effects on the acetylcholine system is not really actually the primary mechanism of action. And unless you're kind of primed to recognize them as being anticholinergic, at least as one of their effects, you may not see that. So that it becomes very complicated very quickly. So people have tried to look at ways to identify what we call sort of the accumulated or cumulative anticholinergic drug burden. And there have been approaches either by taking the patient's blood and looking at what we call a serum anticholinergic activity level. That involves a blood test, and that blood test is not sort of widely available. So we don't do that in clinical practice, but it has been done in research studies, and it does seem to correlate very well. Higher serum anticholinergic activity seems to correlate well with more cognitive impairment. Another approach that's been taken and has been looked at by multiple groups of investigators is trying to develop scoring systems. So developing long lists of drugs and saying certain drugs have no anticholinergic activity, others have modest, moderate, or severe anticholinergic activity. And basically trying to go through, let's say, an individual patient's medication list and assigning scores of, let's say, 0, 1, 2, or 3, and then tallying up that score. And again, those sorts of studies have been done. That's very much a research tool. Most clinicians are not using that sort of system, in part because it's kind of unwieldy. You'd have to spend a lot of time going through things. That being said, though, that's often, again, Chris or Melissa or Dallas or I, a big part of our daily practice is actually going through patients' medication lists, trying to figure out why they might be cognitively impaired, why they might be falling, and all sorts of other things we won't get into today. But again, a lot of it comes back to maybe not explicitly trying to assign these weighted scores, but saying, oh, maybe this drug and this drug, if we could, maybe these are drugs for which there is a less anticholinergic alternatives, or maybe, if there's some way we could try and streamline the list. That's part of what we would consider our comprehensive geriatric assessment, often in conjunction with our colleagues in pharmacy. Again, it's a very time-consuming process, but it's one that can often make a big difference to individual patients. It's also one that, unfortunately, because prescriptions and prescribing to patients with multiple chronic conditions is often a very dynamic process. So, you make a change and things seem better. You come back 3 months later and the list is completely different, and you have to basically reassess. It's something that can involve quite a bit of time. If I just circle back, and I will promise I will finish one more minute. We circle back to this idea, like, remember I said, so, for just older adults in general, we think acetylcholine, or what we call cholinergic tone in the brain goes down, so they may be vulnerable to the adverse effects of anticholinergic drugs. You can imagine, when I said that, I said that's in general for older adults, but in particular in people with dementia, we think that loss is more pronounced. It's actually quite pronounced, and particularly as the dementia advances, that loss seems to be a big part of the issue. So in that population, we often will use drugs to try and boost their acetylcholine levels, whatever remains. You can imagine in that group, they might be particularly susceptible to the adverse effects of anticholinergic drugs. And in fact, sometimes you would think you wouldn't want to prescribe a drug that boosts acetylcholine levels at the same time you're prescribing ones that might kind of suppress its activity by blocking receptors. In clinical practice, though, it often happens for various reasons that drugs with opposing actions are co-prescribed. And so that may come back to something that we may talk about later tonight, and Dr. Frank has been actually publishing on recently, this idea of in older adults who are on a lot of drugs, sometimes one really important thing that we're starting to recognize more is this idea that we have to, rather than prescribe more and more drugs and get into what are often called prescribing cascades, where we prescribe more drugs to treat the side effects of old drugs, maybe it's better actually to de-prescribe, actually formalize the process of stopping certain drugs. And it's remarkable, I think, I know Chris and I have talked about this, a few anecdotes, patients who were on a ton of medications and who were deteriorating, and for various reasons we decided to cut back or hold a number of their medications, and remarkably, sort of blossomed off drugs. So sometimes that's not a strategy that should be underemphasized. So I'll stop there.
This is just like at the symphony, you're holding your applause completely.
Stand up and clap at the end. Great. So I'm going to talk a little bit first about medications that can be helpful for people with Alzheimer's, and I was going to put this slide up too, so I'm glad you put it up, Sudeep. So what, as Melissa said, what happens in Alzheimer's is the nerve cells get damaged, and as a result, there's less of this chemical acetylcholine, which we need for our memory to function to get to where it needs to work. So you have less of these red dots that are showing up, less strong of a signal, sort of engaging the next brain cell, less memory being, memory functioning happening. And we don't have really good drugs to boost the amount of acetylcholine that is made or released from the cells. But as Dr. Gill mentioned, one of the things that we can target is actually once acetylcholine sort of gets into this area, which is sort of a fluid area, it's broken down, it's degraded. There's enzymes in the body which are there to make sure that there isn't too much acetylcholine, and so it breaks it down. And so we actually have some medications that inhibit or prevent those enzymes from breaking down acetylcholine, and as a result, what happens is the acetylcholine that's there is more available to get into the mailboxes and help with memory. So the effect is you're not producing more acetylcholine, you're preventing it from being broken down, and more signal is able to get across. So those medications are called cholinesterase inhibitors. The enzyme they inhibit is called a cholinesterase. That's the name of the enzyme. So it inhibits that, it increases the amount of that chemical that's available, and as a result, memory can be improved. So in Canada, we have a number of cholinesterase inhibitors approved for dementia. They've been around for about 15 years now. The most common would be donepezil or Aricept. Has anyone heard of donepezil or Aricept or seen some ads for that? So that's the most common one. There's a few others like galantamine or rivastigmine. They all work pretty similarly to increase acetylcholine. And what they do for people with Alzheimer's or with memory problems is that temporarily they can increase the level of these chemicals, And they help to sort of keep memory on an even keel. So they don't change the plaques and tangles, which are continuing to accumulate. But what you can see is that on average, people with dementia who take these medications can have a stabilization in their memory for a period of time, or a little bit of improvement. And it sort of slows the rate at which memory would deteriorate without the medications present. So it's great that we have medications that actually can be helpful for people with Alzheimer's. Now, it's not just acetylcholine that's affected in the brain with Alzheimer's. Alzheimer's, those plaques and tangles affect other types of nerve cells as well. So another type of nerve cell in the brain involves a chemical called glutamate. And glutamate's an excitatory chemical. So when it hits another cell, when it's passed from one cell to the other, the second cell gets excited. It's more active. And what happens in Alzheimer's is that there's more of that signal getting across. Unlike acetylcholine, where it's low, other nerve cells, they're overactive. And when glutamate becomes overactive, if you overstimulate a cell, it gets exhausted and it can die. And so there's some medications, one medication now called memantine, or Ebix as its other name, that actually kind of calms down those overactive cells in Alzheimer's. And so that can be helpful as well. It slows the rate at which that overexcited cells are releasing these chemicals, helps to calm it down so that they don't become overexcited and die. So we have cholinesterase inhibitors, and we have this other drug available, memantine, which works in a different way. So those are sort of beneficial treatments for people who have memory problems, and it's all related to these chemical messengers. There's other chemical messengers in the brain too, things like dopamine, or you might have heard of serotonin, and sometimes talked about with depression. So those cells get affected as well. And so when cells that are involved with the production of dopamine get affected, sometimes people with Alzheimer's can develop symptoms that look like other mental illness, where they might hallucinate, see things that aren't there, or they may have false beliefs that people are trying to hurt them or steal from them. They can be very distressing for people. Other chemicals like serotonin, if they're too low, that can cause depression. And so people with Alzheimer's, they'll often have depression, symptoms of depression or depressive symptoms. So sometimes medications that have been developed to treat hallucinations or depression, other mental health conditions, are sometimes used or tried in people with Alzheimer's who have symptoms or problems that kind of look like other mental disorders, but it's different than having depression or schizophrenia. But the same medications are sometimes used to try and help with those symptoms, things like antipsychotics or antidepressants. And they can be helpful for some of those symptoms, particularly if people are very depressed, or if they're really hallucinating a lot or very distressed because they think that people are trying to hurt them. But they can also have, these medications can have adverse events as well, and so it's always having to be very careful about who you start the medications in, and being aware that these antipsychotics, antidepressant medications, which can help restore some of the chemical imbalance that happens with Alzheimer's, don't cause side effects. So some of the things that can happen with these medications, like antidepressants or antipsychotics, are a lot of them can cause sedation. And so if people get sleepy or they're not, or they're sedated, they can have an increased risk of falls, and we know that that's really hazardous for anyone, but particularly for older people where they can break their hip or become injured. They can cause drug interactions as well with other drugs and lead to problems that way. And we also know now that with some of the medications, particularly the antipsychotics, in people with dementia, that they can rarely be associated with very serious side effects. So things like an increased risk of stroke, we really don't know why that happens, and a small increased risk of death as well. So the medications, while they can be useful in some limited circumstances, can come with some significant side effects. Interesting, one of the side effects that these medications can cause is worsening of memory. And so, which is probably not surprising, But what they found is for some of these medications, particularly the antipsychotics, that if you take someone who has Alzheimer's disease and you put them on the antipsychotic, it can be the equivalent of 1 year progression in their disease. So they can have significant memory side effects related to the medications as well that we need to be careful about. And then it comes back to, does it make sense to have someone on a medication that's boosting memory when you're also using a medication that might be impairing it or hindering it? And sometimes it's trying to find a balance between those two. Vicky's going to speak about sort of alternative to medications for some of these behaviors, because for a lot of the behaviors we can use other approaches that don't involve medications. But I did just want to highlight, though, for people who maybe are taking an antidepressant or perhaps an antipsychotic, they're used for other conditions, or benzodiazepines, that it's important to not stop these medications, cold turkey, or they can be appropriate in some circumstances and can cause problems if you stop them suddenly because your body adapts to it being in your system. So it's really important to, if you have a question or a concern about a medication, to make sure you bring it up with your family doctor or your pharmacist before you make any changes on your own. And so, not trying to scare you today, and also want to make sure that you have a discussion with your healthcare provider if you have questions about your own medications that might come up. So I think that was about all I was going to talk about, and I'll hand it over to Vicki.
Just before we move into the non-pharmacological stuff, it's probably helpful just to actually state that none of us have conflict of interest. We're in scientific talks, we always have a slide that says we do not have conflict of interest. Because we're talking about drugs, it's really relevant for people to hear that none of us actually have any sponsorship from pharmaceutical industry.
So I've been invited this evening to share with you a little bit about the Alzheimer's Society. The Alzheimer's Society here in Kingston Frontenac Clinics in Addington is one of 34 chapters across the province of Ontario, and we work in partnership with Alzheimer's Society of Ontario and Alzheimer's Society of Canada. The societies across the province provide service and supports to those walking the journey of Alzheimer's disease or other forms of dementia. So we provide a similar envelope of services across the province. So if you're living here and relocate to another place in Ontario, you can expect some of the same services that you would be receiving here. Those services are, we provide individual support to families walking this journey. We hold support groups for both partners in care and those living with the disease, as well as things such as the lending library, education to frontline service workers. So we spend a lot of our time going out into the community and providing education to personal support workers that are just in the midst of their education, and helping them become aware of how to support a person living with a diagnosis of dementia once they get into the field of their area of expertise. We also we are starting to work a lot more with service organizations. We're hoping to expand into the retail sector, and just making sure that all of our communities are dementia friendly and understand that those living with a cognitive impairment require a different type of support than others, and ensuring that it's out there and embracing the community to help those individuals. So we are located, we're at, for one more week, at the lower level of the Reno Crest Long-Term Care Home, and in October we will be moving to our new location, where we'll continue to provide programs and services there on a daily basis. And as I said, going out into the community. So we look forward to supporting people and working with those that are walking this journey.
I was interested in some of the medications. You alluded to a number of the different medications, But I think for us, particularly when you were talking about the medications who have the anticholinergic effects, it would help me, for example, Dr. Gill, if you could talk about some of those medications or some of the medications that you would not recommend. And then I was thinking about, do you use the SSRIs or do you use MAOIs, or, what are you talking about in terms of the antidepressants? Breaking that stuff down for me would be very helpful.
I'm just, because that's a huge task you just gave him, so I'm going to maybe throw out to the audience if anybody out there knows an anticholinergic medication, maybe from personal experience or from some other sphere, while Sudeep is figuring out, and Sudeep knows every paper that was ever published, so anybody have any thoughts on, as a partial answer to that, from a more personal, not personal experience necessarily, but from kind of a non-medical school perspective? I think I've given them enough time then if nobody's answering.
It's fine. So I think, again, broadly speaking, there are lots of different ways, particularly when you get into all different sorts of different drug classes, to try and classify. But I think one thing that I found useful is to say, well, drugs that we use because of their anticholinergic effects, and then drugs that we use that have anticholinergic effects, but we don't think is part of the primary mechanism. So the class that springs to mind when I think of strongly anticholinergic drugs that we use because of those effects would be bladder anticholinergics. And the classic would be one called oxybutynin. The trade name for it used to be Gitropan, but it comes in many different formulations, including generic formulations. You can get a gel, you can get all sorts of other formulations of it now. There are some other bladder anticholinergics. So there's one called tolterodine, which is Detrol, and there's a long-acting version. And that one you can get. It's limited use through the drug benefit formulary in Ontario. But those are kind of the two older ones, and they're the ones we knew. And I remember seeing a very funny little article called "Dry but Forgetful." So they do calm the bladder down for people who have overactive bladder or urge incontinence, but they can cause cognitive impairment. That was pretty well established. What's challenging is that there are a number of newer bladder anticholinergics, and they are being heavily advertised. They are still on patent, and we do see a lot of ads for them. And I see a lot of patients who are receiving these drugs, and I'll tell you about them in just a second. The hope was that some of these newer drugs might have less in the way of central nervous system activity, and hopefully thus less effects in terms of cognition, so less acute confusion or chronic confusion. And I think that, for me, I guess it's still a little bit of a, I'm not sure, watch this space sort of thing. So the newer drugs, there are three. There's one called solifenacin, which is Vesicare, and some of you may have seen that. The ad for that is kind of the bottom half of a person with their legs twisted together like a corkscrew because they have overactive bladder, and this drug presumably is going to help with that, and it does in fact help with that. The question again is it safer? There's another one called darifenacin, which is Enablex, and I can't actually think, the ad doesn't really stick out in my mind.
They obviously do work though, the ads, don't they?
Yeah. And then the third one is trospium, and I'm struggling with the trade name for that one. But these drugs, again, the thought was they would be potentially a bit safer in terms of their central nervous system activity. And there is some data to support that, but I think it's going to be kind of good. With all new drugs, it'll be a learning curve. So those are probably, that's the class that I think of most frequently with kind of direct anticholinergic activity. There are others that we use sometimes, for bowel spasm, things of belladonna alkaloids. Yes. You'll often see prescribed in hospital, which can have quite a significant central nervous system activity profile. Then there are a variety of drugs that we don't use predominantly for their anticholinergic activities, but can have very potent anticholinergic effects. Probably the most common one, I think you were alluding to them, are the antidepressants, and particularly the old tricyclic antidepressants, or what are called TCAs. And so these would be drugs like amitriptyline, which used to go by the trade name Elavil, and then a variety of others, so doxepine, nortriptyline, imipramine, et cetera, et cetera. There are a whole variety of newer anticholinergic drugs. So the SSRIs, or serotonin reuptake inhibitors. So these would be drugs like, particularly in older adults, we use drugs like sertraline or Zoloft, citalopram, which is Celexa, escitalopram, which is Cipralex, thank you. And these drugs, the thought is that they're, for the most part, very, they are not very anticholinergic, perhaps with the exception of one called paroxetine.
Yes, okay.
And that's Taxil. These drugs, the hope was because they were less anticholinergic, there might be less in the way of falls, and that actually is not the case for a variety of reasons. They do seem to increase the risk of falls in the first few weeks after they're prescribed, especially. Their effects on cognition, though, I do say that I think they are probably preferable to tricyclics, for that particular issue. And then there are a whole host of newer antidepressants that aren't really SSRIs, may have serotonergic effects, may have anticholinergic effects, and there's actually some thought that, the tricyclics, part of their efficacy was actually their anticholinergic effect. They may have effects on a variety of other chemicals or neurotransmitters, including norepinephrine.
Like the SNRIs, is that what you're talking
Yeah,
about?
like SNRIs, and so there's a whole host of other drugs that often there's just one drug populating that subclass.
Yeah.
So there'd be drugs like mirtazapine or Remeron, duloxetine, which is Cymbalta, and all sorts of other antidepressants. So those, I probably stop there. Dallas has already talked a little bit about the antipsychotics, and I think the antipsychotics are particularly complex class or superclass of drugs. They all, as a unifying feature, have some degree of dopamine receptor blockade. And that, not everybody maybe can agree with me on that, but some of them, more than others, can have very potent anticholinergic effects, particularly low potency, typical antipsychotics, chlorpromazine, would be, which I haven't seen prescribed in many years, but of the newer ones that we use a lot more, probably the one that's most anticholinergic would be olanzapine.
So a good principle is anything that's a bit sedating, if it's not a sedative in its label, has anticholinergic properties. So people will often get, because you still see a fair number of people that take Elavil for sleep, which we see and go, oh good, we can stop this and hopefully help the cognition. So I think that often people very rarely use tricyclic antidepressants like Elavil for depression, although they actually work really well. They often use them for things like sleep or sometimes for nerve-related pain. And there's some of the other ones, like a drug called nortriptyline, is very similar but has less of the anticholinergic properties. So you may be able to choose from one within the same class that might be better.
I just want to, if you want to give yourself anticholinergic side effects without a prescription, there's a couple ways you can do that. So the two common drugs that are either sold on their own or in combination with other medications are Benadryl, diphenhydramine, or Gravol dimenhydrinate. And so those medications are often anti-nauseants, used as anti-nauseants or to calm upset stomach or vomiting, or as antihistamines for allergies. So Benadryl and Gravol, you can get them over the counter, and they're very anticholinergic. And a lot of anticholinergic drugs, like it was just said, they have sedating properties. So there's a great medication now called Tylenol Night, or Tylenol Sleep, or Advil Sleep. And it's a combination of a drug that can be helpful, like Tylenol or ibuprofen, along with these drugs that aren't that good, like Gravol or Benadryl. So be careful with those over-the-counter medications, especially anything over-the-counter that's going to help with sleep. It's probably one of those two. And they're really not good for memory, and you can get them in packets of 200 or 300. So it's pretty easy, to get into a bit of trouble with some over-the-counter medications too, even though you don't need a prescription. So look out for anything that has sleep or ease at the end of it. It's probably got some of those chemicals in there.
I'm kind of curious. Oh, go ahead, sir.
I just wondered about The old tricyclics, for instance, as you pointed out, are very useful for pain syndromes. And one circumstance where they're often used is the so-called functional disorders, like gut pain that has no particular reason for it. And there, you can have an effect with very tiny doses, like 10 milligrams of Elavil, or if you're using nortriptyline, the same sort of range. And what about circumstances like that where, as opposed to the antidepressant levels, which may be 10 or 20 or 30 or times as much, do you still think that they could be used in those circumstances properly monitored?
I think one of our big principles is always see if you can use just a little bit, that's probably better than using a whole lot. And in a lot of situations, it can be really helpful to use just a little bit of those medications. I think that one of the things that we haven't talked about is it's not usually just one medication that can get someone in trouble. So sometimes it can be, a whole lot of one of the very anticholinergic medications, but sometimes it can be just a little bit of a number of medications that are a little bit anticholinergic. And so if you toss a little bit in the bucket from one pill and then a little bit more and a little bit more and a little bit more, eventually you get a whole lot of anticholinergic activity. And no one pill is bad. And I've had a few situations where there were 5 or 6 medications on board, and some of them look really innocent and we use them all the time, but when you add a little bit of that and a little bit of this one. So I think you would use anything with caution. We'd never say that the old tricyclics are all bad, or even the bladder medications are all bad and off the table, because it really depends on what benefits they might do, but you want to be careful about how much you're tossing into the bucket.
And I personally would never, I haven't prescribed amitriptyline for years, but I prescribed nortriptyline last week. Once again, very cautiously, but it's just less anticholinergic, but each of them, I have 10 milligrams, I've changed somebody's cardiac, I've done an ECG before to check for the heart electrical activity, and I've done an ECG after starting 10 milligrams, and I've seen a difference. So I think it's still great caution, but it doesn't mean that we would never use it. But I might actually see somebody and say, well, let's switch you from amitriptyline to nortriptyline, as part of just seeing if it works better, or see if it causes less troubles, particularly for someone that's a little fuzzy.
What are your thoughts on eye drops for glaucoma and anticholinergic effects?
That's a great, it's a good question. So the question was.
Oh, sorry, I'll
what
repeat.
are-
Is that okay? Sorry, my question was, what are your thoughts on eye drops for glaucoma and the anticholinergic effects for the seniors?
So that's an excellent question. So if I was to take even a step back from that and say a lot of drugs we think of kind of ones that you ingest, and then we pay less attention to eye drops or even, let's say, inhaled therapies. And one of our colleagues actually in Toronto, who's a respirologist, a lung specialist, did look at some of the anticholinergics that you inhale. There's a very small but real risk there of some of the anticholinergic side effects. She was looking particularly at urinary retention and did find an effect. It's a very small effect, so it's not common, but in a susceptible host might be something. In the eye, now I may actually...
cholinergic, right? It's more usually cholinergic for glaucoma.
Yeah, exactly, and actually I may just pass along to and Dallas's published. Often in people with glaucoma, there's a strong advice to avoid anticholinergic medications because of the risk of worsening their glaucoma, getting a form called acute angle closure glaucoma. Dallas actually is published on that. I don't think I have anything else to
But you want to, because actually,
question.
beta blocker eye drops like timolol will sometimes cause hallucinations. So I had this, I haven't seen it for a while, but these guys probably do. Just talking about timolol and beta blocker eye drops and hallucinations. Have you seen that? I must be the senior. I'm actually the senior person here.
He doesn't look at them. Yeah, beta blockers and you said, so heart block I've seen, or people getting into problems with, so beta blocker eye drops and actually slowing their heart rate, so getting some systemic absorption. I just was wondering what the penalty is for a panel member who refuses to answer questions. I don't think a panel sits just ask questions.
Ron, this is a discussion, it's not a question and answer.
I have 3 questions about Sept. One is, do people get strange dreams with the drug? And the other thing is, when's the best time to take the drug during the day? And the other is, do patients experience an immediate improvement after taking the drug, like on a daily basis, a certain time after taking the drug, they see improvement? Or is it more of a cumulative effect over time?
Yeah, those are all excellent questions. Anybody mind? Actually, it might be really good to get some different opinions on it, but so yes, Sept in particular, I think amongst the 3 currently marketed cholinesterase inhibitors in Canada. So there's Sept, and then Dallas had mentioned rivastigmine, which is Exelon, and then galantamine, which is Reminil. And amongst them, I think sort of anecdotally, and there are some reviews suggesting, vivid dreams can be a side effect. Sometimes not unpleasant, but if they are unpleasant, it might suggest that they take it in the morning rather than at night. And I've seen it prescribed both ways. It's a once daily prescribed cholinesterase inhibitor, as is the Reminil. The other one, Exelon, is either twice daily if taken by mouth, or there's a patch that you can take as well. So yes, definitely vivid dreams might suggest taking it in the morning. And sorry, the third question was?
How quickly cumulative effect?
Hang on, let me just put a patch on. Yeah. Is it like, and this is from personal experience, I work with patients with dementia, but also my father has dementia, and he feels he's more clear cognitively of the few hours after he takes the drug. Is that like a placebo effect, or is that documented that there's an immediate effect, or because recently he's been recommended by his physician to take the medication before bed so that it's in his system working for the morning, because he normally takes it at noon with food because he didn't tolerate it without. So, but he feels his mornings are very cloudy, and after he takes the medication he feels immediately better. So I'm just wondering, should there be an immediate effect, or is it usually cumulative over?
I'd love to hear some of the other panels. I'm just going to say, I'm a little bit, I haven't heard that story, but the reason I might be a bit skeptical is Sept amongst the 3 has the longest half-life.
Okay.
And so it should definitely have the sort of steady state throughout the day,
Right.
regardless of whether you take it in the morning or at night. Maybe a question a little bit around dose, and again, sometimes within an individual, if he finds it more effective at night, I'd be willing to try it. But I would love to hear what others have to say as well about this.
Not related to the medication necessarily, but certainly I've seen a lot of patients who have dementia or Alzheimer's who it takes them a while, even without the medication or with to sort of warm up, or that they may even have, especially with more advanced dementia, have sort of what they call confusional arousals, where they partially come out of sleep for a period of time, or they sort of gradually wake up and become more clear over the course of a few hours. And so I wonder if that, maybe a part of it, that it takes people a bit longer to get completely out of sleep and functioning at their top level when they have memory impairment.
Right, yeah.
So that might be a component of it as well.
I'm just curious, what's the word on the street out there about cholinesterase inhibitors? If you ask the average family physician, they have quite usually fairly consistent opinions. So I'm just curious, from the folks that are not in medicine, what have you heard about these medications? That's the Septs and the Reminils and the galantamine. Exelon, thank you. I always forget that.
So my experience with most of these medicines is that the medics, the doctors, don't give sufficient information on the side effects of them. There's too much information given about the effects of medication, and not enough practical or kind of basic information. You're going to have diarrhea, you're likely not going to sleep very well, or you could develop a lot of anxiety. In our experience with medications, all of the medications we took, and my memory doesn't allow me to rattle them off, but all of them caused serious side effects, whether it was 5 milligrams or half a milligram to 10 or 15. And so as a result, we cut all of those out, and so the lifestyle, is 1,000,000% better, right?
Yeah.
And you're dealing with a person who is, other than the memory loss, is extremely healthy. You know, very active, extremely healthy. So it's just kind of my take on medication generally. So while I'm talking now, then I won't talk anymore. In the book I just read, it's I believe the title is 100,000 or 10,000 joys of Alzheimer's and 10,000 sorrows of Alzheimer's. And it's about a couple, the caregiver and the patient, who are very much into meditation. And so the question, and in particular, and into Buddhism and the principles, the 5 principles of Buddhism, and practicing it in their lives. And so the question is, what is your experience in that form of medication to help treat the cognitive impairment? That's it.
I'll hand that one over to the other people. Dr. Gill? It's a great question. We're appreciative of the question by trying to evade it.
I love your
That's a hard question.
So I
withdraw.
I'll hand it to somebody else for the second part. But you know, I loved what you said at the beginning, because it probably is something we maybe didn't emphasize enough. All drugs are double-edged swords, and you know, unfortunately, you know, physicians know our prescribing pad is kind of our hammer. Everything's a nail, right? And we like to, we often focus on that. We do try, you know, and I think there's a real emphasis on trying to take a step back and say, well, these drugs, all of the drugs that we have, unfortunately, I would say for neurological diseases, right, we're at a very primitive stage, right? Like, so we know a little bit about the neurotransmitters. It's such a primitive stage. So the things actually directed more specifically at this amyloid cascade that gets out of whack. You know, there have been attempts, unfortunately none successful so far. The drugs, we target one system. Like we said, acetylcholine is expressed everywhere else in your body, many other organ systems. So like you said, absolutely, you know, it may have some modest beneficial effect in the brain. Often in the same patient or in other patients, you may get diarrhea, you may feel dizzy, you know, you may have increased urgency because it's the opposite of the ditropin. So there's all sorts of kind of trade-offs, and unfortunately there are no magic, you know, sort of magic bullets that sort of have only benefit and no harm. The meditation, I was just going to, I think Dr. Seitz was no,
Well, I wanted to think about the meditation, because remember what I said about exercising the brain, and I think it's really true that it's a use it or lose it phenomenon. And one of the lessons that I've learned over and over in working with people who have experienced changes in their brain is that there are usually so many abilities that are still quite good, and so many abilities that some go faster than others, and it depends. And what you really want to do is use the brain as much as you can in the ways that it works best, because you keep those abilities, you keep all those chemicals flowing, you keep in practice. And I think meditation, I don't know how many people have tried it. I've tried, I'm not very good. It's hard work. It takes a lot of focus and concentration in your brain. And what it does is every time that you practice that, you keep certain pathways. Those signals in those pathways working, and every day you give them work, that keeps them rolling along. So I think any activity, whether it's meditation that takes concentration, or Sudoku, or memory games on a computer, or playing with the grandchildren, whatever it is, there's no magic one, but I think it's a really, really good strategy, and it's side effect free.
Good.
Because I think it's a great point, and I think a lot of family physicians will say, oh, well, these drugs are useless, we never prescribe them, because there's a lot of, appropriate skepticism about them. I think that, I learned from Melissa, actually, that, one thing she said to me was, unfortunately, you never know who's going to get the benefit. So I usually will say, I think it's worth discussing, and then kind of have a discussion about some of the side effects, and I'm very willing to get rid of them if they're worsening somebody's quality of life because of the side effects. But I do like to consider trying them with people, because there are a few people where it's very clear that they get benefit, and unfortunately you can't sort of kind of bind them with the bottle or something like that. You can only do it by a trial, but I think we should do a better job of discussing side effects frankly, and listening to the reports of them, and just moving away from the medication.
Yes, I'm not anti-doctors. I happen to have one in the clan that gives me lots of trouble.
Two things. First, on your question about what do we think about Aricept and Reminil and all that kind of stuff. My wife was taking both Aricept and Reminil, one after the other. She started with the Aricept, and I'm not sure why we changed, other than we wondered if it would have a better effect. I don't think we could really tell whether it was effective or not. And eventually, I asked that she be taken off those medications, just because I didn't think it was doing anything but causing other effects. So I really don't know. I guess we agreed to it because we thought, there's some hope. Maybe it'll make life quality better. But whether it really did or not, I don't think I know.
Well, there's a thing that I think everybody should look up, which is called Choosing Wisely, and it's an American project that came to Canada, and it's looking at trying to use resources more effectively, not only to save money, but just to have better patient outcomes. And one of the newest recommendations in this Choosing Wisely gives you an idea of what they're like. It sort of says, if the cholinesterase inhibitors are not working, stop them. It has things like, before surgery, people should not have routine ECGs, unless they're at risk. It's those types of things. It covers every sphere of medicine, but I think it's got a lot of patient resources that are quite helpful. And this seems like a pretty informed audience. You can probably read some of these lists of do's and don'ts and get something from them. But that's a new one that kind of reflects what you push for, and hopefully the physician would choose wisely too.
I have a question, and that is, is the drug Nabilone being considered as something useful for treating dementia?
So, does anyone hear what Nabilone is? Okay, so Nabilone is a synthetic cannabinoid, so it's like one of the active components in marijuana, but it's a synthetic medication, and it can be helpful for managing various symptoms. It's been used in mental health, for example, treating things like PTSD, post-traumatic stress disorder, anxiety disorders, because it does have a calming effect on people. And it is a medication that is being investigated right now. In fact, some colleagues in Toronto are heading up the biggest study funded to look at Nabilone to treat symptoms like anxiety or agitation or emotional distress in people with dementia, with the hope being that this medication perhaps isn't associated with some of the side effects with antipsychotics. Although knowing how Nabilone works, it's hard to imagine it wouldn't have some effect on sedation and falls. falls as well, because it does have those side effects in people who don't have dementia. But it is being looked at as a treatment for behaviors in dementia, so like anxiety or emotional distress. I'm not aware of it being used as a treatment to improve cognition or to prevent dementia or treat the underlying causes, but it is now being prescribed, and there's probably, we see it being used in clinical practice now as a treatment for behaviors in dementia in a few instances, but it's still very early on. And I would say we, at least the antipsychotics and the antidepressants, they're the devils we know. We know a lot about them. They've been studied extensively in people with Alzheimer's. That's how we know the side effects and how well they work. And Navalone and other medications, it's really not known if they work well, if there's benefit with them. And we don't really know the risk profile either with the medication. So I've used it on very few occasions for people who have not responded to just about everything else. But that's about the only time I've used it, because it is just an unknown at this time by and large, but one that is generating a lot of interest.
I work in healthcare. I also provide care for my father who has dementia. He's one of those patients who's on, I think, between 15 and 20 different medications. So tonight has been somewhat of an eye-opener. But what my question specifically relates to is, since February of last year, he has had 6 surgeries, and every time he has had a surgery, his recovery time from a cognitive perspective has been longer and longer and longer. We've only just got him back to a reasonable level. He's having another surgery on Friday, and I wondered if you could comment on anything that would make it easier after. And what are the effects of the general anesthetics on cognitive issues in dementia?
So in terms of surgery, so surgery is for anyone, it's a massive stress on your system. You know, you have a major injury to your body occurring because of the surgery. Your body responds to that with inflammation and a release of chemicals to try and fight off this injury. And even in the fittest, cognitively intact people, it has an impact on your cognition, usually temporarily for most people. But in people with dementia who, whose cognition is compromised already, that insult can cause cognitive problems that can persist beyond surgery, and it may actually, in some cases, and surgery is necessary for a lot of people. Some surgeries are more elective, but for people with dementia, it may actually accelerate, cognitive decline or sort of contribute to memory problems because that inflammation, that stress response is toxic to the brain. And so if you have an injured brain and you stress it, it's going to be, more injured. The role of anesthesia doesn't look like anesthesia really has much of an independent impact above that of the surgery. So studies have been done looking at, just having a general anesthetic where they put you off to sleep and you're paralyzed and you're unconscious. Is that worse for your brain? You'd think it would be, but is that worse for your brain than having a local anesthetic like a spinal? And it looks like actually they're very similar in terms of the cognitive side effects, and it's really the act of undergoing the surgery that is causing, the greater stress on the body and the mind than the anesthesia.
I think Dal's done a really nice job of describing. One thing, again, if we come back to that idea, of confusion, being either acute or chronic, and thinking of cognitive disorders, acute and chronic, as Dal was saying, so that idea of people with a chronic cognitive disorder like a dementia, their reserve is lower. They are particularly susceptible to acute cognitive decline, delirium. I mean, often I sort of think in my mind, unfortunately, the nature for most dementias is progressive decline. The rate of decline can vary over time, sometimes for reasons we know, like inappropriate drugs like anticholinergics or benzodiazepine. Sometimes, even when it's not clear, people can decline. Definitely surgery or other major medical illness, like a bad case of pneumonia or some other major organ dysfunction, can contribute to one of these episodes of delirium where there's a kind of a sudden decline. The recovery from that often is not complete, and it sounds like that may be the case that you've experienced. And definitely, sometimes those episodes of delirium can kind of tip the cognitive course downward. So I wish we had sort of better strategies to try. There are the things that we can try to do to prevent. In hospital we often try to get. There's a volunteer program at Kingston General and many other hospitals called the Elder Life Program. The hospital.
They're right here.
Oh, great. More of it. But I think a lot of the best evidence is actually in the prevention. And actually, I don't know if you want to speak more about your programs. I find it very, very good.
Yeah, it just, we help to
Hold on.
Vanna's coming. We just try to help with decreasing any further cognitive decline with things like mobility, simple things like providing a newspaper every day, calendars, conversation, meal companionship, all those kinds of things to get people grounded to where their baseline was, so they don't lose anything. The other arm of the program is the Queen of Let's Get the Foley Out. And so things like that we don't always necessarily consider as things that would deter the patient from returning to their baseline that are so important, and as quickly as possible to eradicate as many barriers as possible to help those folks along. And I think we do a really good job of doing that. And our goal is to get people home as soon as possible so we don't make them sicker in hospital, because that happens.
I think the other thing is that, kind of, if somebody's on 15 medications, looking for anticholinergic ones before the surgery and trying to get rid of them, for example, somebody who's taking a bladder medication, that's a perfect time to stop it because incontinence is a huge issue, obviously, but compared to being delirious in KGH for 3 weeks, it's a small price to pay sort of thing. We always kind of joke about orthopedic doses of things, and so I work in orthopedics at times, and I'm forever sort of saying, instead of 2 to 4 milligrams of Dilaudid, can you start at 0.5 and titrate it up based on the needs? So if the 0.5 is great, that's great. If they're still in pain, then bump it up to 1, and then bump it up to 1.5, and then bump it up to 2, as opposed to having a big range that's too big a dose. So they're all really small things, but even, I'm sure you're also getting hearing aids back in and glasses and trying to decrease sensory stimulation. So, and then unfortunately those things that are harder to maintain, like good fluid balance afterwards, etc. Interesting study from many years ago looking at post-op hip patients found that if you had inadequate pain control, you actually, the dose of the pain medication was inversely correlated. So if you were on a higher dose of medication, but it was well chosen and titrated up, you had a lower risk of getting delirium than if you had terrible pain control. So, once again, the double-edged sword, the narcotics cause confusion, but poor pain control can cause confusion as well, so it's kind of a real balance as usual. Question from somebody who should be thankful for helping to organize.
I guess I wanted to ask, it's kind of the chicken or the egg question, but what comes first, the delirium or the dementia? And does the delirium cause the dementia? Because it felt like that in our situation.
That is a good chicken egg question, because I think the answer is kind of yes to both. Definitely, I think you can see people who have a known dementia are definitely at risk for episodes of delirium. Their cognitive reserve is lower, and cognitive, pre-existing chronic cognitive impairment in the form of the dementia is a major predisposing factor that heightens the risk for an acute confusion or delirium. Often, though, we look at the history the other way around too. People who have told us, Dad had surgery. He was fine before he had this episode of delirium. Never really made a full recovery, and at some point down the line, 6 months or 12 months later, we decided we need to have this evaluated and a diagnosis of dementia was reached. Was there something maybe subtle that the surgery and the episode of delirium unmasked? That would be my typical explanation. I've definitely seen both ends of the spectrum.
Just related to that, what like Dr. Andrews said, with the changes, the plaques and tangles that happen in people's brains, those things are often brewing for 10, 15, 20 years before people start forgetting their car keys, and it's clear that they have dementia. And so I often think that, someone getting confused or developing, it seems like memory problems emerge after a major medical event like a surgery. Sometimes it might be a complication related to it, but often I wonder if that person hasn't had some plaques and tangles building up. They haven't manifested yet in terms of memory problems, but that extra bit of stress and a bit of extra time has been enough to sort of unmask it. And certainly the delirium surgery would be the classic, of sort of unmasking that, a process that may have happened anyways, just a bit later, but was probably going to happen at some point had the person, lived long enough and the disease process continued for a longer period of time. So,
do you think that some of it as well is that, speaking from some of the hospital experience, right? You have a patient who has been functioning but in their own surroundings at home. So you don't necessarily pick up on some of the cues, even when they have their pre-admit clinic for a booked surgery or anything like that. And there's no real alarm bells that are ringing. Then the person has their surgery. And for a variety of reasons, the bed has to be moved like 4 times. They're put in the room with somebody else who is up all hours of the night, or there's lights coming in, or from a nursing perspective, anytime after 4 in the morning, it's free reign. If you've ordered me blood work to do on my patients, and I've got 9 patients to do, I'm going to start. You woke me up or you put your bell on at 4, this is a good time for your blood work, and we're just going to systematically go around. I think that there's no wonder why, there's a number of triggers within a hospital setting that can help to bring some of these things to light that wouldn't necessarily have come. I was also going to comment on that anesthetic piece. I find it really interesting that there's no evidence, kind of like that sort of full moon effect, and there's no evidence to show that women give more or have more babies during full moons, or people go nuts during full moons. They can't prove it, and yet we see it as nurses. My experience as a nurse is that we tend to have a lot more confusion after general surgery than we ever have after a spinal. And yet, it sounds like there's nothing to back that up.
and I think, the anesthesiologists also are, they select different anesthetics for different people, and they're also quite careful, and I'm married to one, about, for someone they are worried because they have that in their mind as well. The general is probably not good for the cognition, and if this person kind of looks like they maybe don't have 100% cognition, I'll give be more careful with that patient. And so there may be other factors, related to people who get generals that make them more susceptible to confusion, or also, people who are quite confused and uncooperative. It's tough to give a spinal to as well. And but the studies they've done, even experimental studies, controlled trials, really haven't shown any convincing evidence. Although it's a very hot topic, it's been unconvincing to this point, which is quite surprising.
I think a concept that's similar with that, the delirium unmasking the dementia, is that one of the classic side effects of antipsychotics is actually Parkinsonism. And it doesn't take long for particularly some of the older antipsychotics like Haldol, for example. So these days we might use an older antipsychotic like Haldol for delirium, if we have the right criteria, because we try to avoid using them. But if you have an older patient with dementia who might be on it for months and months and months back in the old days, often within a few weeks they would start to get Parkinson's type features, so more shuffling gait, trouble with drooling, slowing of physical movement. And that can happen even with some of the newer medications. And sometimes you'll stop it because you recognize it and the symptoms will persist, which usually means that they had early Parkinson's and the medication had just brought it out. But that's a really important side effect to be aware of for us prescribing antipsychotics, because it's very subtle, and if you see the patient fairly regularly, you sometimes can really, really miss it.
The other thing about being in the hospital when you have a vulnerable brain is that it's unfamiliar. And I think that has a huge impact. It's like when families tell me that their dad was fine until they took him to visit their sister, and he was in unfamiliar surroundings, and he started getting up and wandering at night and all of that. The hospital's unfamiliar, and that's going to contribute as well.
And we see it just moving within, like 4 doors down within the hospital.
Yes.
You know, they just get settled, and then they move, as we said here, and the move literally on the same corridor will sometimes cause people to be, I've got somebody right now. Is there one final sort of comment or question before we wrap up?
I have a question. Is there any correlation, or has there been any studies regarding ADHD, ADD, and developing dementia down the road?
I sure hope not.
Just curious.
Not that I'm aware of, and it's a tricky one to study because most people with ADHD are diagnosed in childhood, and so you need to follow them ahead, for several years. It's not that you can't be an adult and diagnosed with ADHD, but that's much more sort of recent that we're sort of picking it up in adults. So it's not known. It wouldn't surprise me, that it increased your risk because people with ADHD probably have a little bit less cognitive reserve, than someone without ADHD. But I would guess it's probably a fairly small risk factor as compared to having like a traumatic brain injury where you were in a car accident or had a fall and a major concussion or something, where that type of brain change is much more clearly associated with the development of Alzheimer's later on.